rates of exceeding 30 to 60%. Infections lead to prolonged hospital and ICU stay and places a burden on our healthcare systems with increased costs. And most importantly, they have limited treatment options due to increasing resistance. Therefore, early diagnosis and appropriate treatment of these infections are very important to improve outcome and reduce mortality. The surveillance data from ATLAS 2018 to 2022 show a clear global rise in CRE infections, with the higher prevalence shown in the green line in Latin America, followed by the Asia Pacific region shown in the blue line. This shows that our region is a hotspot for carbapenem resistance. Carbapenem resistance in Enterobacterialis vary also by bacterial species and by geographic region. We can see in the left panel, Klebsiella pneumonia has a resistant rates that generally range between 10 to 20%, with the highest burden seen in Europe, Russia, South Asia, and Southeast Asia. On the right, we see E. coli, which has a lower prevalence of carbapenem resistance, typically between 1 and 10%, with high prevalences in Southeast Asia and South Asia. In Taiwan, CRKP rates have increased from 5 to 9.5% between 2018 and 2022 based on our TSAR national surveillance data, while CR E. coli remains low, below 1%. Hospital-acquired CRE infections, shown as the red line, remain consistently higher than community-onset infections in the blue line. However, a slight upward trend in community-onset CRE in the Asia-Pacific region, as shown in this left upper panel, is concerning, suggesting that CRE is no longer confined to hospital settings and may be emerging from the community. What are the mechanisms underlying carbapenem resistance in gram-negative bacteria? Well, resistance may arise from acquired mechanisms, such as mobile genetic elements, transposons, plasmids that may carry resistance genes and carbapenemase genes, or it may arise from chromosomally encoded mechanisms, including efflux pump upregulation and loss of porins. For CRAB, resistance is driven mainly by OXA-like enzymes and cephalosporinases. CRPA, in contrast, is mostly due to porin loss, efflux pump upregulation, and MC over expression. For CRE, however, the key mechanisms are carbapenemases, including class A, B, and D enzymes. On the right, we see the red boxes indicate carbapenemases, and the carbapenemases are a subgroup of beta-lactamases and can be classified by the Ambler classification into class A and D, which are serum beta-lactamases, and class B, which are zinc enzymes, also known as metallo-beta-lactamases, or MBL. MBLs are particularly concerning because they can hydrolyze a wide variety of penicillins, beta-lactams, and all carbapenems, leading to high levels of resistance. Clinically frequently seen carbapenemases, including class A KPC and the class D OXA48. And the MBL enzymes, including VIM, IMP, and NDM, are also frequently seen. The distribution of carbapenemase types varies across region, but it is particularly concerning to see the rising prevalence of class B MBL genes in the Asia-Pacific region, in Latin America, and the Middle East Africa regions. This trend signals that there is an increasing burden of these highly resistant MBL-producing organisms in these areas. More recent data from ATLAS 2020 to 2022, analyzing over 2,000 clinical isolates of carbapenemase-producing CRE, show that more than 50% in the Asia region are caused by MBL classes, and an additional 11% carry dual carbapenemases and often involving an MBL component. These evolving resistant patterns and the growing dominance of MBLs have important implications for empiric treatment choices for CRE infections. In Taiwan, we are similarly observing a rising proportion of carbapenimases producing CRE, reaching up to 75% to 78% for E. coli and Klebsiella pneumonia. Notably, there was a significant increase in Class A KPC in E. coli, up to 41%, and for OXA48-like enzymes for Klebsiella pneumonia, up to 25%. For NBLs, there was not a statistical significant increase. However, we see up to 24% of E. coli and 7.9% of Klebsiella isolates do harbor NBL genes. The emergence of NBL and the spread of KPC and OXA48 enzymes have major implications for clinical practice since they reduce the effectiveness of many beta-lactams. They restrict our choices of empiric treatment and make rapid diagnostics and timely use of newer agents more important than ever. In addition to national surveillance, it is also important to review your own local epidemiology, particularly those in your hospital if available. And these are data from the Kaohsiung Veteran General Hospital from 2018 to 2023, presented in ID Week 2024, analyzing carbapenemase producing CRE isolates from 2018 to 2023. We found that 46% of CRE were carbapenemase producers, and even more concerning is also the high prevalence of Class B NBLs, reaching 34% for CRKP and 66% for E. coli, and over 90% for species such as Enterobacter and Citrobacter frundi. The increasing burden of Class B NBL producing CRGMB requires vigilant surveillance. It is important to know the mechanism of resistance, as this directly determines which treatment will actually work. For Class B NBLs, CRE, none of the currently available novel beta-lactamase inhibitors work. Recommended treatment options include cefiderocol and Aztreonam avibactam. In contrast, CRE harboring Class A KPC and Class D OXA48 carbapenimases, ceftazidime avibactam remain active. Ceftolozane tazobactam is active only against CRPA and not active against CRE. Imipenem relebactam and meropenem valbobactam provide good coverage of Class A KPC CRE, but are less effective against the Class D OXA48 producers. Ceftazidime avibactam has now been in use globally for over almost a decade, and emerging resistance has been reported. A meta-analysis reviewing 136 studies up to September 2024, and including over 500,000 gram-negative bacilli isolates, found that resistance for ceftazidime avibactam has risen from approximately 5% before 2020 to 13% after 2021, with an overall resistance rate of 10% and highest in the Asia region, reaching 90%. Among Enterobacterales, resistance rate is 6%, and for glucose non-fermenters, including Pseudomonas aeruginosa and others, resistance rates reach up to 25%. In Taiwan, corresponding resistance rates for Enterobacterales is 10%, and for non-fermenters, 32%. More recent data from Atlas 2020 to 2022 provides some reassurance. Among KPC carbapenimases, the green bars, and Class D OXA-type enzymes, the blue bars, ceftazidime avibactam susceptibility remained high across all regions of the world. In addition, Aztreonam avibactam, shown in the red bars, show exceptionally high susceptibility of over 99% for all regions. This indicates that at present, ceftazidime avibactam continues to be a reliable option for CRE Class A and Class D carbapenemase producers. With Aztreonam avibactam entering the market in the near future, we will finally have another treatment option for CRE infections, particularly those caused by NBL-producing organisms. In Taiwan, we see a similar pattern. Data from the SMART study 2017 to 2020 show high ceftazidime avibactam susceptibility with the green bars, reaching 93% for CRKP and 88% for CRE. coli. Cefiderocol in the blue bars also showed excellent activity of over 95%. These findings show that ceftazidime-avibactam also remains a viable, reliable treatment option for CRE infections in Taiwan, and cefiderocol is an effective alternative option. How does resistance to ceftazidime-avibactam develop? There are several key hotspots for mutations within the KPC enzyme's active binding site. The most important is the KPC omega loop, highlighted in blue. Even a single amino acid substitution such as D179Y can significantly alter the enzyme structure, leading to reduced binding of avibactam and clinical resistance. Globally, more than 140 KPC variants with omega loop mutations have been reported, and this number continues to grow with ongoing evolution of antimicrobial resistance. Another important mechanism of resistance in Enterobacterialis are the production of MBLs. The B1A enzymes are responsible for the Enterobacterialis MBLs. These enzymes causes resistance to all beta-lactams except for monobactams, and that is aztreonam. Future development of beta-lactamase inhibitors active against MBLs, such as taniborbactam, will be essential to expanding our therapeutic options. Mortality from MDR-GMB infections also vary by pathogen and by the mechanism of resistance. In an Italian study done in the Alarico network involving more than 1,000 patients, show that for carbapenem-susceptible gram-negative bacilli bloodstream infections, mortality rates are 13% and increases to 26% for KPC-CRE and to 36% for MBL-CRE. On multivariable analysis, MBL-producing CRE carried the highest risk of death with a 5.8-fold increase in mortality. Importantly, early appropriate therapy was the only factor that was protective, reducing mortality by 47%. A more recent Italian study, also from the Alarico network, focusing on bacteremic HAP-VAP patients, reported substantial mortality of 46.5% with carbapenem-resistant organisms versus 30% for those that are carbapenem susceptible. Over half of the patients with carbapenem resistance were in the ICU, and patients with carbapenem-resistant infections were more likely to have VAP and also less likely to have received adequate antibiotics within 24 hours. Only 31% received adequate antibiotics. Treatment outcomes were better for those patients who received ceftazidime-avibactam compared to those treated with colistin-based regimens and other therapy. Independent predictors of mortality in this study included host factors, severity of illness, and importantly, timing of appropriate therapy. Receiving appropriate therapy within 24 hours reduced mortality by 50%. Interestingly, in this study, carbapenem resistance itself was not an independent predictor of death. The key clinical finding is that resistance does not kill. Rather, it is the delay in effective treatment that is the killer. An earlier Taiwanese study done in 2016 on ICU patients with nosocomial pneumonia showed that CRAB was the predominant pathogen, followed by CRPA, with a high in-hospital mortality of 46%. On multivariable analysis, escalation of antimicrobial therapy was associated with a 30% reduction in mortality. Colistin did not demonstrate an overall benefit, but a benefit was observed in the subgroup with the sickest patients, those that had a SOFA score of greater than 7. This study also demonstrates that timely escalation or earlier appropriate treatment are critical for improving survival in MDR-GMB infections. So across both the Italian and Taiwanese studies, we see a consistently high mortality associated with CR-GMB infections, and it is clear that early effective therapy is crucial to reducing mortality. This then brings us to the importance of rapid diagnostic tools that may facilitate timely decision making by rapid identification of pathogens, detection of resistance, enabling earlier initiation of appropriate treatment. Rapid diagnostic platforms available for detecting carbapenem-resistant GMB include the BioFire Film Array PCR, the NG Carba Test, Carba5, and the Expert Carba-R. These PCR tests or lateral flow assay offer high sensitivity and specificity, providing excellent accuracy with rapid turnaround times. However, their usefulness is limited by high cost, particularly for PCR-based systems, and by the fact that they cover only a limited set of resistance genes. Therefore, a negative result does not exclude carbapenem resistance, as resistance due to other mechanisms may still be present. Rapid diagnostic tests have been shown to improve outcome. This is a very early study demonstrating that incorporating these rapid diagnostic tests for MDRO significantly shortened the time to appropriate therapy from approximately 48 hours for culture-based diagnosis to 1 to 4 hours using these rapid molecular tests. This enabled earlier escalation of antibiotics and de-escalation of antibiotics when appropriate. However, these benefits are maximized only when combined with and integrated into active antimicrobial stewardship, ensuring that results are interpreted promptly and translated into timely action. Another study from the United States also showed that using a rapid molecular test, PCR, to detect KPC in CRE bloodstream infections cut the median time to active therapy from 50 to 24 hours and resulting in a reduction of mortality up to 63%. A recent network meta-analysis involving 84 studies and more than 25,000 patient encounters showed that rapid diagnostic tests can significantly improve outcomes in MDR infections, reducing mortality by 27%, shortening time to optimal therapy by 29 hours, and also reducing the length of stay. However, again, these benefits were observed only when rapid diagnostics were integrated into active antimicrobial stewardship programs. And this will ensure that with the rapid results actually translate into change in early choices, change to early appropriate treatment choices. Lastly, we come to treatment options. Listed here are the novel antimicrobial agents available for managing MDR organisms. These include the new beta-lactam/beta-lactamase inhibitor combinations, such as ceftazidime avibactam, ceftolozane, tazobactam, imipenem, relebactam, and also the Siderophore cephalosporin cefiderocol. In addition, aztreonam avibactam is a monobactam combined with avibactam that is active against MBL enzymes, and cefepime-taniborbactam is a future option that is not available yet in the Asian countries. Current international guidelines for treatment of CRE bloodstream infections recommend ceftazidime avibactam, meropenem avibactam, imipenem relebactam as preferred agents. For MBL producing CRE, recommended options including cefiderocol or combinations of ceftazidime avi with aztreonam, which provides coverage of the MBL enzymes. In Taiwan, combination therapy with polymyxin B or colistin plus tigecycline remains an alternative option for settings where newer agents may not yet be available. So in conclusion, CRE and MBL producing CRE infections are increasing both globally and in Asia. Early effective therapy is the strongest determinant of survival. Rapid diagnostic tests must be combined with antimicrobial stewardship program to have the maximized benefit. Empiric treatment choices should be guided by local epidemiology and carbapenemase mechanisms. However, increasing prevalence of CRE NBL producers is concerning, and I'd like to emphasize and end with that we need to continue vigilant surveillance of resistance trends, and the smart, responsible antibiotics is needed to prolong lifespan of available agents so that we will continue to have effective treatment options available, and that when given timely will improve patient outcomes and reduce mortality in CRGNB infections. Thank you.
Okay, thank you, Dr. Lee's excellent lecture. And I think she pointed out the epidemiology from